This talk is an overview of low-carb nutrition and how we can use food as a tool to treat and prevent chronic disease. The objectives. We're going to look at some metabolic conditions, including the metabolic syndrome, insulin resistance, and hyperinsulinemia. We'll look at common pathways and mechanisms to these chronic conditions. We'll look at clinical tools to best evaluate insulin resistance and also cardiovascular disease. We'll compare standard diets to low-carb diets. And we'll finish with practical approaches to treatment and prevention. Not to bother you with statistics, but it's clear we're dealing with a triple burden of disease. We know them well, and they are obesity, diabetes, and heart disease. And it's fair to say that at least 2/3 of the adult U.S. population have one or more of these conditions. Now, if we could find a common mechanism that addresses these conditions, we'd be making headway in terms of helping our patients. And there is such a mechanism. It is the metabolic syndrome. So let's spend a few minutes on that. So the metabolic syndrome is also called the insulin resistance syndrome because it defines the central mechanism. Now, the insulin resistance syndrome was first described by Dr. Jerry Raven in 1988 at the Banting Lecture Series. Now, the lecture series is named after Frederick Banting, who co-discovered insulin back in the 1920s. And let's not confuse him with William Banting, and this is an interesting story. William Banting lived in the late 1800s, and he was an undertaker who was overweight. And he wrote the Letter on Corpulence, where he discovered that reducing bread and potato from his diet would help with weight loss. Specifically, that's a low-carb diet, and we now refer to that as the Banting diet. And I had the opportunity to actually visit the grave of William Banting when I was in Kensington, London a few years ago. Now, I understand that the Bantings are related, but just an interesting story, and I digress. So let's get back to the main theme, that of insulin resistance. And Dr. Raven identified 5 criteria, and they included glucose intolerance, hyperinsulinemia, where the insulin levels would rise, and atherogenic dyslipidemia, which really looks at the ratios and the quality of the cholesterol, looking at triglyceride to HDL, looking at LDL particles. And what you can see is that LDL concentration is not included. What's interesting is that measurement of atherogenic dyslipidemia is merely an indirect measurement for glucose and insulin metabolism anyway. We also look at elevated blood pressure and abdominal obesity. And why this is important: if you had 3 or more of the criteria, you were at great risk for developing type 2 diabetes, atherosclerosis, coronary heart disease, and stroke. And now we understand that the insulin resistance syndrome is actually associated with many of the chronic conditions that we see in modern society. Now, when I first learned about the insulin resistance some 25 years ago, it really made a lot of sense to me because it defined a central mechanism. And also it defined a diet, a best diet, specifically low carb. And we'll talk a little bit about that. And then during the same era, we meet Dr. Joseph Kraft. And his research looked at hyperinsulinemia, which is a simple clinical tool to diagnose diabetes and prediabetes at a very early stage, what he referred to as diabetes in situ. And during Dr. Kraft's career, he performed the insulin assay in 16,000 individuals, where he administered a load of glucose and then monitored insulin and glucose over a 5-hour period of time. And let's take a look at that. It's rather interesting. So here is the pattern of euinsulinemia, or a normal insulin response, where the insulin level does not rise over 60 microunits. And superimposed are the 3 patterns of hyperinsulinemia. And you can see that the insulin level can go up almost to 200 microunits. Now, I'm not showing you the glucose graphs, but what Dr. Kraft identified is that the insulin level will go up years before the glucose levels rise. Now, Catherine Croft reanalyzed the data and came up with a simple clinical tool, and that is to measure a 2-hour insulin. And so here you can see if your 2-hour insulin after a glucose challenge is less than 30, it would be normal. And if the 2-hour insulin is over 40, you have a problem. And this is what we do each and every day in our office. And thanks to the work of Dr. Reven, Dr. Kraft, and others, we now understand the natural history of type 2 diabetes. And we can take a look at the timeline. So here at year 0, you get your diagnosis of type 2 diabetes. A fairly easy diagnosis. Your hemoglobin A1C is over 6.5%. Your fasting glucose is over 126. And should you measure a 2-hour glucose after a challenge, it would be over 200. Now the question is, we're really helping our patients when we make the diagnosis at this point? And I say not, because there's so much going on years before. So let's step back 20 years and indeed see what's going on. Well, again, Dr. Kraft identified hyperinsulinemia 20 years before the diagnosis of type 2 diabetes. Unfortunately, most healthcare professionals never even measure insulin, and it's not in the guidelines. Dr. Kraft, however, proved the point. And then 15 years before the diagnosis of type 2 diabetes, you're insulin resistant. And you can measure that through a home IR or a glucose clamp. A glucose clamp is a research tool. And then 10 years before diagnosis, you can measure impaired glucose tolerance. Should you do a glucose challenge 2 hours after, you'll see that the glucose will rise to 140 milligrams per deciliter or greater. At this point, you might see fasting blood sugars rise. 5 years before the diagnosis, subclinical cardiovascular disease would set in if you measure it properly using the calcium score, and we'll talk about that in a little bit. But as you can see, there's a problem for decades, and the individual and even the clinician are unaware. And then, of course, once you're type 2 diabetic, you're an absolute mess. And so the point here is that you must do the right measurement, or you're not going to know that there's a problem. And we must have an early level of suspicion in terms of the metabolic syndrome and doing these tests. So when it comes to the metabolic syndrome, let's talk about the elephant in the room. And that, of course, is nutrition, and more specifically, low-carb nutrition. Now, Dr. Kraft and Dr. Reven, they stuck with the mainstream guidelines. What did they know about nutrition? Dr. Reven was an endocrinologist. Dr. Kraft was a pathologist. But it was later in their career that they realized the benefit of low-carb diet. But we feel that they missed this golden opportunity to advance nutrition science. But now it's our turn. So what I'd like to do is spend a few minutes and compare standard diets to low-carb diets. Now there's different ways to define standard diets, but for the purpose of this presentation, let's call it the perfectly balanced healthy diet, just to point out the fallacies. And so here's a pie chart illustrating the macronutrients in this perfectly balanced healthy diet. You can see that a third of the energy comes equally from the macronutrients, including fat, protein, and carbohydrate. This must be right because it's mathematically precise. Okay, there's mathematics for you, but let's talk about some of the conventions. The first convention is that all calories are alike, so it doesn't matter what macronutrient the calorie comes from. And also, since it's all about calories, the food quality is unimportant. This is all based on the first law of thermodynamics, and we'll talk about it in a minute, but that just simply defines what a calorie is. It seems that this positive and negative energy balance is what determines our health, what we call calories in and calories out. And these conventions emphasize the law of physics over the law of physiology, and I don't particularly like that. So the first law of thermodynamics, we learn about that in the combustion chamber or the bomb calorimeter. And this is a closed system, and you insert an organic material and you ignite it and you measure a rise in temperature, and you can determine how many calories are in the organic material that you put in the chamber. Interesting, but all this demonstrates is calories in equals calories out. Is this how the body works? Well, yes, it does, but it's much more complicated than this. Some more conventions. We should reduce total fat and saturated fat in the diet. Well, why should we do that? For weight loss, number one, because we all know that fat is caloric dense. It contains 9 kcal per gram compared to protein and carbohydrate, which contain 4 kcal per gram. So to create a negative energy balance, we simply eat less caloric dense fat in the diet. Okay, convention number one. The second convention, and it's a convenient one because it goes along with the first one, that we should reduce the fat in a diet, specifically saturated fat, because it will reduce, supposedly, our cardiovascular risk. Why? Because saturated fat elevates that bad cholesterol, which is true, but it supposedly clogs the arteries. And cholesterol is somehow this dangerous substance that when it reaches a certain concentration in the blood, it smashes its way through the blood vessel wall and causes disease. This is much too simplistic an approach. And we address this by reducing saturated fat and replace it with carbohydrate and polyunsaturated fatty acids, including canola, corn, and soybean oil, what we refer to as industrial seed oils. And now what we understand, it is precisely these recommendations that the cardiology institutes recommended to us some 50 years ago that is actually causing the problem that we're trying to address. Pity. Another convention, that the individual has a lack of willpower. People fail to eat less and exercise more. It's their own fault. And I tell you, this mantra to eat less and exercise more fails most always. And what we get is serving up disease for over 50 years, a half a century. And we need a better solution, and we need a better approach. And this is where we start to think about the idea that all calories are not alike, especially in living systems. Why is that so? Because the food energy is processed differently. So let's take a look at food energy processing. So we talked about the bomb calorimeter, and we can measure the calories of food. But when it comes to living organisms and the processing of energy, we want to look at cellular respiration, and that's measured in the metabolic chamber. So the metabolic chamber is a closed system, and you can put a living organism, such as a human, into it. You can exercise that person, you can give them food, you can fast, and measure things such as VO2 max, aerobic threshold, fat oxidation, and lo and behold, under different circumstances, the macronutrients are processed differently. Now guess what? Calories in equals calories out. But again, that's not what we're interested in looking at. We want to look at the processing of the energy. So looking at energy processing, this is an energy flow chart. And rather than calling it calories in and calories out, let's refer to it as energy in and energy out. And so again, we can process the energy. We can partition the energy, meaning we can make a decision whether to use the energy that comes in immediately or to store the energy. We can decide whether to use stored energy or not. And then energy out. Imagine all the metabolic processes that require energy. And then the fact that we need energy to process energy. And then there's feedback. Feedback is a very common mechanism in living organisms. It's a self-regulating mechanism. And two examples of feedback include satiety and hormones. And let's dive in a little deeper. So it's fair to say that metabolism is complex. There are many hormones and biochemical pathways that need to be considered. One hormone of particular interest is insulin, and we refer to that as the fat storage hormone or an anabolic hormone. In its presence, it's a signal to store energy. But more importantly, insulin regulates energy, that of energy homeostasis. So insulin decides what to do with the energy that's available. And we know that insulin is most sensitive to dietary carbohydrates. It's basic physiology. And now let's consider what happens when metabolic disease sets in and how it affects these energy pathways. We all agree that carbs and easily digestible processed food drive appetite. Well, in the state of hormonal dysregulation, that gets much worse. And yes, we see hormonal dysregulation, and we also see energy or calorie overload. And in the energy flow chart, we are accounting for both the hormones and also the calories, both important. So let's dive into metabolic disease and hormonal dysregulation and discuss insulin resistance. And the best way to do that is through the insulin resistance cycle. So let's spend a few minutes. So on the upper left, we eat food. And let's say we overeat. The body has an innate ability to store energy. So it can store it first, converting glucose to glycogen. And the glycogen is stored in both the liver and the muscle. Important to understand that the glycogen stores are a rather small fuel tank, and it fills up rapidly. But we have a second location to store extra energy, and that's in fat tissue. First, the subcutaneous fat, which is a healthy organ. As we continue to eat and perhaps eat more, that extra energy will get stored in the healthy subcutaneous fat, and we begin to gain mass. Fat mass, we gain weight. And there comes a point when the adipose tissue says, you know what, we're filling up and we have enough energy. We don't want any more energy. So the subcutaneous fat becomes resistant to the insulin signal and becomes insulin resistant, sending a signal back saying that they're full. Now, the problem is the energy is still coming in, and the pancreas through insulin production and the liver through de novo lipogenesis continue to pump and force fat energy into adipose tissue. At this point, the subcutaneous adipose tissue becomes dysfunctional and inflamed and more insulin resistant to the point where it says, that's it, we cannot take in any more energy. But guess what? The energy still has to go somewhere. And so we see it lay down in ectopic fat tissue, including the viscera and the organ fat. This is a location where adipose tissue shouldn't be in the first place. And this leads to further metabolic derangement, hormonal dysregulation, inflammation. This drives appetite. And what do we end up doing? We eat more food. And this is the insulin resistance cycle. And there's two endgame results here. The first is adiposity. Not only is the fat energy trapped in adipose tissue, including the subcutaneous fat and the ectopic fat, but it can't get out because of these exorbitantly high insulin levels. So it trickles in and it can't get out. And the second result is it drives our appetite, something fierce. Now we have to understand that metabolic disease is not just going on in adipose tissue. It's occurring virtually everywhere in the body. And that's why we refer to this as metabolic mayhem. The biochemistry is disrupted, and it leads to inflammation and oxidative stress. So let's talk about metabolic mayhem. So we have another Banting lecture in 2018 from Dr. Jerry Schulman, and he discusses his mechanistic research looking at insulin resistance, and he describes it again as an energy imbalance and overload condition. And it leads to ectopic lipid deposition of insulin-responsive organs, including muscle, liver, and fat. And all he's saying is that fat is accumulating everywhere in the body. This leads to inhibition of insulin signaling, and there's a breakdown of the biochemistry at the cellular and the mitochondrial level where energy is processed. And ultimately it leads to inflammation and oxidative stress, including free radicals, reactive oxygen species, and advanced glycation end products. Now, we don't see disease just in these organs. We see disease in virtually every organ in the body, including the brain, the blood vessels, you name it. And again, biochemistry breaks down, hormonal dysregulation. It is metabolic mayhem. So what are we going to do about this? Well, this is where the low-carb, high-fat diet comes into play. And we're going to talk about some of the conventions. So here's a pie chart of your typical low-carb, high-fat ketogenic diet. It includes 70% of calories from fat, 20% of calories from protein, 10% of calories of carbohydrate. And that fat intake does include saturated fat. And we could use any pie chart here as long as it wasn't that perfectly healthy balanced pie chart, just to make the point that the macronutrients are processed differently. So the conventions, like I just said, macronutrients are processed differently. Carbs are fattening and inflammatory. Why is that? Because carbs drive insulin more than protein and fat. This is, again, basic physiology. Carbs trigger appetite because of the wild fluctuations in the insulin and the glucose. I'm happy to report again in 2020 that the American Diabetes Association again recognizes the benefit of low-carb diets. The CFO of the ADA just went public stating that she's treating her type 2 diabetes with a strict low-carb diet, and she got off of insulin. What a wonderful endorsement. Regarding heart disease, important to understand that saturated fat by itself is not the cardiovascular disease villain that the heart associations have been telling us it's so for over a half a century. We're again dealing with a metabolic disease that damages the lipoprotein that carries the cholesterol molecule itself, and the arteries. And these seed oils, these industrial seed oils, canola, corn, and soy, are very unstable in the blood because of the molecular structure when you compare it to monounsaturated and saturated fat. I'm happy to report that there was a wonderful peer-reviewed paper in the Journal of the American College of Cardiology that came out this year, and the conclusion was that limiting saturated fat is not supported by the current evidence. And we have a growing body of evidence that continues to show the benefits of low-carb diets, and we're very happy to see that. So what happens when you put somebody on a low-carb diet? So this is an image of a dam, and it really represents energy trapped in the adipose tissue. So that energy is trickling in and it can hardly trickle out. So you take a diabetic patient, you put them on a low-carb diet, and very rapidly their appetite is under control, their glucose is regulated, and most importantly, the insulin levels begin to drop. And what that does is it opens up the insulin floodgates and the energy stuck in adipose tissue comes pouring out. It gets packaged as lipoprotein and distributed throughout the body as energy. And the patient loses weight and feels great. So it's low carb to the rescue. And there's this metabolic advantage for diabetics when you understand the physiology. And the supposedly high-calorie diet seems to defy thermodynamics. Well, no, it isn't. You're just not accounting for the calories and the hormones correctly. And most of you may realize that eating less and eating less often is spontaneous. And there's a psychological advantage because we're focusing on satiety rather than deprivation. Now, maybe calories don't matter under this scenario, but imagine this. You have a type 2 diabetic that needs to lose 40 pounds. So you put them on a low-carb, high-fat diet where they're eating less than 40 grams of carbohydrate, and their appetite's under control, and they lose weight, and they feel great. Now, hopefully, they'll be eating less at the end of the period of time. But for some individuals, they still may be eating a bit too much. And I tell you, if they continue to eat that way, they're going to hit a weight loss plateau, or the weight's going to start to come back up. And so this is the idea that both the hormones and the calories and the quantity of food all need to be considered. So this brings us to this two schools of metabolism. And on the one side, we have the calorie camp, the calorie in, calorie out group. And on the other side, we have the endocrine camp or the hormone camp. And even the vegans and the meatheads got into this debate back in January. And on the calorie side, we have the vegans who called it veganuary. And on the endocrine side, we have the meatheads calling it organuary. So again, it's the calories versus the hormones. And what I submit is that we have these two schools of thought, and they come together in perfect harmony and form the school of food energy and metabolism. And the best part, it's bipartisan. Okay, so I'd like to shift gears now and discuss more about heart disease. And most important to understand that atherosclerosis is a metabolic disease just like everything else we've been discussing. And we see damage to the lipoprotein that carries the cholesterol itself, and the blood vessel wall. And we address insulin resistance, and we look at the quality of the cholesterol, not the quantity. And to understand that when you look at cholesterol, again, it's just an indirect measurement of insulin and glucose metabolism. And it's this proper measurement that helps us to predict risk. Now, what did Dr. Kraft have to say about cardiovascular disease? He said, those with cardiovascular disease not identified with diabetes are simply undiagnosed. And Dr. Kraft is simply saying that there are many heart patients that don't realize they have underlying metabolic disease, such as hyperinsulinemia. And so it's clear in the literature that there is a strong relationship between diabetes and heart disease. But when it comes to clinical medicine, unfortunately, that relationship becomes a bit blurred. And we see this all the time. We have diabetics that come into the office that don't realize they have subclinical heart disease. And on the other side, we have heart patients that don't realize that they have diabetes or prediabetes. So the question, why is there such a disconnect? Well, welcome to the Framingham Distraction. Yes, that's Framingham, Massachusetts, where back in the 1940s, they studied the population for decades to see which ones had heart attacks and which ones didn't. And they identified factors that seemed to be associated, and we know them today as risk factors. And they include bad cholesterol, smoking, hypertension, and yes, diabetes is in there, but they really underemphasized the importance. And since the original Framingham work, they've come up with different guidelines, tools, and risk calculators, all with a central theme. to lower the bad cholesterol. And therein lies the problem. These guidelines don't measure glucose properly. They don't measure insulin. They don't measure for metabolic syndrome. And the diabetes risk is absolutely buried. But I'm happy to report in 2018 that the guidelines are getting better. And I kid you not, this is the first year that the cholesterol guidelines have included the metabolic syndrome, and we're very happy to see that. The guidelines also include the heart calcium score, and we'll talk about that in a few minutes. So this is a complicated slide, but it shows the metabolic markers that we think should be addressed when it comes to cardiovascular disease. Now this slide brings into the discussion nutrition, and specifically we're comparing low-carb diets to low-fat diets thanks to the work of Finney and Volek et al. And so the top of this diagram shows us measurements of atherogenic dyslipidemia, and the bottom are measurements of insulin resistance and insulin metabolism. And the yellow bars that mostly move to the right show the benefits of a low-carb diet compared to the low-fat diet on the red bars. And at the top of the chart, again, the measurements for atherogenic dyslipidemia all improve. The yellow bars move further to the right, including triglyceride to HDL ratio drops, triglycerides drop. HDL is the one yellow bar to the left that goes up, but that's actually favorable. And then you can look at the insulin markers below. Insulin improves, glucose improves, abdominal fat, and body mass. Now this is associational data, but again, it demonstrates the benefit of dietary intervention and the metabolic markers that we should be looking at when it comes to cardiovascular disease. So the bottom line, when it comes to cardiovascular disease, it's the insulin, stupid. And I'm referring to my dear healthcare colleagues, of which I am one. And the point is that we're dealing with a metabolic disease, and we need to think about cardiovascular disease in that light. And it's not simply about measuring bad cholesterol. And if we simply focus on the bad cholesterol, the LDL cholesterol, we're going to miss so many that are at risk. And we like to say if it weren't for LDL cholesterol, everyone would be on a low-carb diet, perhaps. And most importantly, this is all about a diet and lifestyle approach. We're not talking about pumping the patients full of medication. So cardiovascular imaging. Imagine if we had a tool where we could look inside the body, visualize directly the disease process, and determine risk based on that. Well, we have such a tool. It's called the heart calcium scan. And again, it's direct visualization. We can see the calcium with plaque underlying. Important to understand that unlike a blood marker, which is just a loosely associated risk factor, the calcium score is determining risk based on direct visualization of the disease process itself. That's a night and day comparison. Important to also understand that imaging really provides us with historical data compared to blood markers, which tell you what's going on at the current time. And I like the analogy of comparing the calcium score to looking at the health of the fuel tank, whereas the blood marker is measuring the fuel itself. And we can use this tool to track progress and to motivate our patients, to empower them to make change. And as I mentioned, the calcium score is now included in the 2018 guidelines, although it's in there as a decision-making tool and not a screening tool. We think it's still serving a wonderful purpose, and we're very happy to see it there. So here's the calcium score. It's a CT scan of the heart. It uses a little bit of radiation, such as a mammogram, and it takes a gated image, multiple images and slices of the heart looking at the tiny little coronary arteries, and it looks for calcium where the plaque is underlying, and you add up the calcium, you get a total score. Now here I have two images of two different individuals. They're only one slice each. The individual on the left, circled in green, is the left anterior descending artery. We refer to that as the widowmaker artery. And you can see that there's no calcium. And we do have the data on the entire scan. There's no calcium in this particular scan, so that's a 0 score. That's a perfect score. And then on the right is a different individual, and you can see that the LAD is circled in red, and there's a lot of bright white calcium. So that's a high calcium score. Now we don't have the complete series, but for comparison we can say that the individual on the left has a 0 score, and the individual on the right might have a very high score, say 400 or 1,000. And again, this is the beauty. We are directly visualizing the disease process, and we can determine risk based on that. So with the calcium score, you add up the calcium and you can determine your 10-year risk. And on the top, if you have a 0 score, your 10-year risk of having an event is less than 2%. Versus if you have a score over 1,000, your 10-year event rate goes up to 37% or a 20x risk. So it's an incredible difference. And this data is based on 40 years of reproducible and quantifiable information. I do mention to patients that the 2018 guidelines do talk about statins for higher scores, and so we have that discussion. But also, we have the discussion that we should not underestimate the importance of eating real food and low-carb diets. So we'll finish up with clinical assessment, evaluation, and treatment. Important to understand that not everything is insulin resistance. And so we have examples of two individuals who are insulin sensitive on the other side of the spectrum. They're actually metabolically healthy. And on the upper left is that slim, insulin-sensitive individual that we hate. They're perfectly healthy. It seems that they can do whatever they want and never get metabolically ill. Well, it's always a snapshot in time and it can change, so we want to encourage healthy living. The individual on the right, again, insulin-sensitive, metabolically healthy, but overweight. And we do see quite a few women that fall into this category. And you measure the metabolic markers and they're completely normal. Now I tell you, if we put them on a low-carb, high-fat diet, they might lose a few pounds, but they'll rapidly plateau or the weight will start to come back and they're frustrated. And so the approach is different to the insulin-sensitive, overweight individual. Still, we want to focus on finding a macronutrient mix that best controls appetite so the patient doesn't eat as much, but a little more carbohydrate, a little more protein, and eating just enough fat to fill is probably a good approach. And then we have the insulin-resistant individual that represents 2/3 of the population. And on the bottom left is this slim insulin-resistant individual we refer to as TOFI, thin on the outside, fat on the inside. And this is typical of many Asians in our population, that they become diabetic without very much weight gain. And then on the bottom right is the typical type 2 diabetic that's overweight. And again, these represent 2/3 of the population that are insulin resistant. And it really is an argument for a low-carb diet to be included in the dietary guidelines. So knowing the insulin spectrum of your patient, understanding where they lie in it is very important. And so on the left you have the insulin sensitive individual, and on the right you have the insulin resistant individual and everything in between. And throughout life this can change, but understanding where a patient lies on the spectrum is important in terms of addressing treatment approaches. So clinical evaluation. The most important thing is to have an early level of suspicion. In other words, if you don't do the right measurement and you don't think about it, you're not going to see that there's a problem. So if we can teach healthcare professionals anything, it's to think about metabolic syndrome early on and how to treat it and diagnose it. We can measure body fat, other anthropomorphic measurements. We can do some simple lab testing such as a fasting glucose, hemoglobin A1C, standard lipids, all done in the office, or we can send out for advanced lipid testing if you wish. Some more nuanced testing such as the insulin, HOMA-IR, C-peptide, hsCRP. We've been doing the 2-hour glucose challenge for over 20 years, measuring the insulin. We've done it in thousands of patients, and it really provides some useful information. And then, of course, the cardiovascular imaging that we just discussed. And so this is an overview or a summary of the advice that we give patients to treat a healthier life. We want to cut out processed foods and limit the sugar and the grain and those industrial seed oils and replace them with real food. We want to control the carbohydrate intake. We want to prioritize protein, although protein usually takes care of itself, and we generally want to eat just enough fat to fill. Now, if it's working well, appetite will be under control, but if we're having an appetite issue, we have to consider tweaking the formula. How about some common themes, such as a low-carb Mediterranean diet? Everyone loves a Mediterranean diet, although we don't quite know what it is. But in this context, we would define it as a diet that contains meat, non-starchy veggies, and natural fats. And I hope that most people would agree that that is the basis of a healthy diet. Supplements for some, addressing stress, sleep, and sunlight are critical. Movement and activity. Now, we're not trying to create a negative energy balance, but there's a lot of psychological benefits. There's cardiovascular benefits. It helps with blood glucose, and it helps build up muscle to be active. Now, when it comes to viruses and pandemics, the goal is to be a healthy host should that virus come knocking at the door so we can fend it off. And lastly, and most important, patient education and support to empower our patients to make positive change. So this is our last slide. And it really brings us back to the beginning of the talk. And the point is that food can be powerful like medicine. Now, I, of course, am not the first to say this. It was the father of modern medicine, Hippocrates, who said it thousands of years ago. But perhaps we weren't listening up until now. So that concludes my presentation. I hope you found it informative. Thanks for your time.